Okay, so hello everyone. I realised that I probably went a bit too long on Tuesday, and that it would probably be worthwhile having just maybe a slower video to go back to as well, and if you missed anything, because it is quite a dense topic. So hopefully this can be a resource, as well as the Alfred people who can't make it. Hopefully this covers a few things. I know we get a lot of arrhythmia teaching, but sometimes it's by cardiologists, and what they know, what we need to know, are not the same things. If I work out how to add text, which is a big if, I'll maybe put some time markers in of where things start, but no promises. Otherwise, maybe similar timing to what was on Tuesday night. So we'll go through these things, a little bit of anatomy, all the parts of an ECG in terms of doing one and understanding the physics, which is yuck. Interpretation, then some of the Bradyarrhythmias, atrial arrhythmias, and ventricular arrhythmias, as well as I've got some examples at the bottom that we can work through. So, starting with anatomy, which is always fun, I struggle to wrap my head around where things go. So I always found that this flatter, you probably can't see my mouse, can you? Oh, maybe you can. Okay, I don't know, leave a comment below. Can you see it? I don't know. So I always liked this flatter image. So you've got the two main arteries that come off the aorta, which is the left coronary artery and the right coronary artery. Some people might trick you up sometimes and ask, oh, what are the first branches of the aorta? And technically speaking, it's the coronary arteries. So your left goes into your left anterior descending, which comes down the front, and that's your, sometimes called your anterior interventricular. And it keeps going and supplies the left marginal and the circumflex. And on the right side, you have the right marginal and the posterior interventricular. So your posterior interventricular artery always supplies the apex. But a concept that might have been raised before is about dominance. The majority come from the right and a minority come from the left coronary artery, which is probably for the best, given we know that given the left looks bigger, it's going to supply more. And honestly, if you got a clot in there and it supplied the apex, you'd be pretty stuffed. So it's definitely for the best. Given the right coronary artery supplies the posterior aspect of the heart, so here, it also affects your pacing nodes, which means as a complication, you're more likely to have arrhythmia from any sort of infarction. So moving on. Oh no, here we go. So going back, you can see the septal areas, as well as that anterior portion corresponds. So it works out. Okay, it does not like that. Okay, so this is the picture from before, so it's still got the anatomy, so we can work out what's happening. But your anterior portion is V1 to V4, and that's supplied by your left anterior descending. So that makes sense given what we saw before and what we know. Your lateral leads are the green ones here, supplied by your left circumflex, which makes sense. You're moving away from the anterior aspect of your heart, moving laterally around. And the way I remember it is it involves AVL, so L for lateral. The other important one is the inferior leads. So that's a little L at the bottom, which is kind of confusing. Probably don't remember that. I wouldn't remember that. That's a bad way to remember things. But it has AVF in it. And that's supplied by the RCA, which is here. And then the posterior, which we sort of spoke about being the posterior interventricular, and this is where it supplies the apex, whether or not it comes from the right or the left. And these are in leads V7, V8, and V9. So we'll go through where those leads are in a bit. But you technically need to do a posterior ECG. But I'll tell you guys a sort of neat way of working out what's happening. And as I've written here, you can see some changes in the anterior leads because they're pretty much opposite to the posterior segment of the heart. So I'm quite a visual person, and I can just see this in my head on the ECG, and that makes more sense to me because when I'm looking at the ECG, I can picture this over the top of it rather than learning it as a list. But what works for some people might not work for others. So as this comes into relevance for all of the arrhythmias, so working out if you've got a slow heart rate, where's that coming from? And if you've got a really fast heart rate, where might that be coming from? So the SA node, which you guys all got in class, is the sinoatrial node, and this picture here gives an indication of what supplies that. So you can see that majority are supplied by the right, but a few are supplied by the left. So if you had an infarction of the maybe quite proximal in the left coronary artery, and you had supply to your SA node by your left artery, you would be more likely to have an arrhythmia. But for the vast majority, it has to be a right-sided infarction or an infarction in the right coronary artery, which overall is less common. So the SA node, which I'm sure you guys are all quizzing yourselves at home, beats at what rate? Exactly 60 to 100. Oh my gosh, I heard all of you. That was great. I won't do that again, I'm sorry. So the AV node is also supplied by the right coronary artery, which we said before, beats around 50 to 80 beats per minute. So as you can see, the further we get down, the slower we go. And for the bundle of His, which is on this diagram in between, so that's when it's all together, and the Purkinje fibers, which are these ones further down, there's going to be quite a difference between the two of them, but it's quite slow as well, so 20 to 40 beats per minute. And this is when you're starting to get to the level where you are not maintaining your cardiac output, and so you're going to be quite symptomatic at this point. This is a good picture. It overlays what components of the heart are involved in the ECG segments. So the P wave involving atrial depolarization, and then the PR segment is the delay from the AV node down the bundle of His, which makes sense if that's long, you're having an AV node delay. The QRS complex involves your bundle branches, which is wide in a bundle branch block. And then your Purkinje fibers and the repolarization of the ventricles is encompassed in your T wave. So this picture is just a good reference. So using that image and having a look at how fast some of the expected values for the different components of the ECG, we can see that 3 is a pretty nice number. So if you're ever worried, 3 is going to be in there somewhere, and generally less than 3. So your P wave, which we said is the atrial depolarization, is less than 3 small squares. The P wave, which is important to note that it's from the start of the P until the end of that flat segment there. So it's the interval rather than the segment. And that's 3 to 5 small squares. The QRS should be quite narrow, which is less than 3. The ST segment should be less than 3 again. And it should also be at the same level as the PR segment. And a little bit of change is not too dramatic. Your T wave, which we don't really worry about the length of it, but mainly how high it goes or if it's inverted. and the QT interval is 11. But a good rule of thumb is that it should be less than half of the R to R interval. So when you look at it, and if you think your T waves are really, really stretched out, then maybe there's something going on there. And U waves out here can be pathological, but they can be physiological sometimes, but we'll go through that. So this goes through ventricular depolarization, which is pretty logical, but the QRS, so it goes, as we can see here, it goes down a little bit, then up, then back down. So it's got different waves to it, and that's just because of the way that the depolarization moves through the tissue. So as we can see here, it starts towards the left side of the right side of the heart, continues towards the apex, completes up the right side, and then finishes on the left, which if we think about the anatomy of the heart, and as we can see here, it's a lot thicker on the left-hand side. So it's not unexpected that the left-hand side would finish later than the right, finish depolarizing. And the thickness of the tissue can change this whole mechanism, and that's when we see issues with our left bundle branch blocks, right bundle branch blocks, and this here, anterior and posterior fascicles rather than left and right. Not super relevant, it's just sort of the pathophysiology behind a bundle branch block. And this picture is just a little bit bigger for your reference as well. So the placement of the leads, as I said to to everyone that came on the night, the image here isn't quite accurate, and really 5 and 6 should really be in a straight line with V4, but we'll go through the placement of the leads. And just what I've written here is that technically you place 12 leads on the patient. So say you have these ones and these ones at the bottom. But it makes it gives 12 views of the heart, and that's because they augment some of the leads, and essentially they do some maths and extrapolate extra information from the leads we already have, and they exclude the right leg, which is your ground or earth lead. So going through this, V1 is placed on the right sternal edge in the 4th intercostal space. 1, 2, 3, 4. Even though, I mean, a rule of thumb from Taylor and O'Connor is that your nipple is over the 5th, and that's where your apex is, so maybe this person's nipples are a little bit too high. I'm going to go into plastics, I've decided, and I'm going to change this man's nipples. Okay, good. This is fun when I'm by myself. I'm so sorry, everyone. So V1, 4th intercostal space on the right sternal edge, and then we just flip it over to the other side. We do the 4th intercostal space on the left side. And this, given you can sort of see that, okay, well, if there was an issue on the other side of the heart, this would probably pick it up. It's your poor man's posterior, which is just something interesting to know. And your V1 would be the best lead to look at if you want to focus in on what your SA node's doing. So that's also your sort of where you're going to look for that. It's always good to do V4 and then V3, because V3 sits exactly in between the two of them. But V3 is between them, and it's pretty much on the 5th rib and maybe 2 to 3 centimeters away from the sternum. V4 is in your mid-clavicular line in the 5th intercostal space. V5 is the anterior axillary line, and it's on a horizontal line from V4. So really this should be a little bit lower and probably a little bit further in, but obviously on a 2D image we'll forgive them. V6, again, so it's going to be mid-axillary line, and again lateral to V5, so just on a horizontal. Now V7, 8 and 9 are your posterior leads. So it's not common, I mean, maybe in a real life situation you might be asked where they're put, but it's not common, and it's probably something that the nurses would do or help you with. So V7 is the posterior axillary line, still in a straight line from we were carrying it on from V4. V8 is in your mid-scapular line, again in a straight line, in a horizontal line, and V9 is your left spinal edge, so just on the side of where your sort of that what's it called, a spinal process is. And what people commonly do is they'll just take these three off and replace them into these three locations, and when they get the ECG printout, they just rewrite over the 4, 5, 6, and they'll replace it with 7, 8, 9. And maybe they'll write up the top posterior ECG so no one gets confused. Although that is quite confusing. Then the rest of these, so RL, right leg, but it doesn't actually contribute to the ECG, right wrist, left ankle, and left wrist. So this is the physics, to be quite honest, of ECGs. It's here if you want it. If you don't, it's fine. It does sometimes orient you to what's happening in the ECG, which can be helpful, I suppose. So a positive deflection on an ECG is movement towards a positive electrode. So you don't really need to know what positivity or negativity the electrodes are, but just knowing that if it's up, it's moving towards that electrode. And that can really help you with knowing where the bulk of the muscle is. So in your left ventricular hypertrophies, you can see a massive peak, and that's just because there is so much tissue there that all of the electrons and the ions in a depolarization are moving, so like there's just heaps of it and it's moving towards an electrode, and that's why it's so positive. And the opposite's true for a negative deflection, that it's going away. For our bipolar limb leads, so bipolar meaning that it's between 2 points, and the three that we use for our bipolar leads are the left arm, the right arm, and the left leg. So as I said, your right leg is earth. It's discounted. And what happens here is you compare those three together, and you guys might have seen that triangle, which is really confusing, but essentially it's just saying that you compare these 6 sort of to each other, and you come out with 3, and they're the leads 1, 2, and 3, which are on the left hand side of your ECG. The other ones that we use are the augmented leads. So the A is augmented, V is unipolar, and then L, F, and R are the names. And what they do is they compare the central point of that triangle to each of the corners, which I'll show you on the next slide. And that's how we get extra information from less leads, and that's why when we use our 10 lead ECG we get 12 leads. So this is what I was talking about, where they're comparing one arm to the other, an arm to the leg, and another arm to the leg. And then these are all your augmented leads, so they compare it to the midpoint, and then we place on these red arrows here are our V1 to 6, and that's how we get all of the views. Not strictly relevant, but if you really like physics, or you're going to be an electrophysiologist or I don't know, maybe it's interesting. And if it is, I'm happy for you. Alright, so this is where we get into it. So the components of an ECG that we're going to look at, we're going to make sure that it's the patient that's sitting in front of us. Because you absolutely do not want to look at a healthy patient's ECG when you think your patient's having a heart attack, or vice versa. So some of the patient details that we're going to check is their name, their date of birth, when it was taken. So sometimes you'll get some old ECGs, if they're in pain. And also, as I said, if they have old ECGs. So asking if the patient was in pain is quite important. And that's because sometimes we can find things on ECGs that, strictly speaking, aren't normal. But if your patient is asymptomatic, if your patient is sitting up talking to you, looks absolutely fine, then it's not our biggest worry. We need to make sure that we're looking at our ECG in the context of the patient, and that's with all investigations. If you have a patient who, and I suppose within reason, but if your patient has low iron or borderline iron, but they aren't tired, they feel fine, and you just did it because you like spending money, then, you just have to go with what the patient's telling you. That's an aside. That's like a life learning tip, but whatever. Also having a look at the calibration, the rate and rhythm, if there has a normal axis, the P waves, PR interval, QRS, ST, T, QT, and the U, which I'm sure you guys all know the components. So this slide here talks about what can happen at each of those steps. So when you look at the rate, is it fast, is it slow? The rhythm can be irregular or regular, etc. You guys can read. These are probably pretty much all of them as far as we need to know, as far as I know. And yeah, good to be able to pick up. But the biggest ones will be an irregular rhythm, being AF, and that will probably be a fast rhythm as well, so the absent P waves, and one of these guys, so an AV conduction block. You could be given a STEMI, and then in real life, working out what's a bundle branch block will be a very common issue. Okay, so where we start. So we're going to start with the patient details. In reality, you're meant to check the patient with 3 points of ID, but this doesn't happen very often. And then, as I said, the symptoms at the time. So some normal, oh my gosh, I'm so good sometimes. I just take the words out of my mouth. Sorry. Sometimes you got to toot your own horn, you know what I'm saying? So I went through that. The date and time of the ECG. So is there anything else to compare to? Is this a really acute change? And is there any change over time? So that's quite important. If you see a patient who just has T-wave inversion, you're going to make sure that that's not getting worse and it isn't becoming a STEMI. If they're on any medication, so if a patient has a really slow heart rate, maybe it's pathological, maybe it's iatrogenic, maybe it's because of us. For completion's sake, we can have a look at the calibration. So it should be 25 millimeters per second, and that's usually written at the bottom of the ECG. And then that big tall column on the left-hand side of the ECG. And it's important to look at AVR and make sure that that's negative. If it's not, then the leads are probably put on wrong, which means like maybe a med student did it. Or maybe I did it because I've done that before. So just as a revision, what does a small square represent in time? And that is 0.04 seconds, and a large square, which is 5 small squares, which makes it 0.2 seconds. The rate. So it's good to start at a rate, because that's also going to give you a really good starting position as to what you might think this is. So we'll go through some of the causes in a second, but having a look at how you work it out. This is a really common approach, this where you count all of the QRS complexes and you times it by 6. It assumes that it's a 10-second strip, which sometimes might not be the case. And look, I used to do this. I think it's easier, but a lot of people and our nurse educator really preferred the 300 method, which is what I do now from peer pressure, apparently. I don't have an answer for you. I think all roads lead to Rome. If you get the right answer, then it's fine. I think there is a bit of a benefit for this counting all of the complexes for irregular rhythms, rather than this one, which assumes that there's the same distance between all of them. I always wrote these numbers down on the side of my OSCE piece of paper. I mean, if it sounded cardiac or if I thought I was going to get an ECG, just because sometimes that maths, even though it's like relatively simple, it's hard to remember sometimes. And if you're starting to get, I've buggered that up again. That should be 75. Sorry, everyone, for the 4. It's hard to remember and to get it right, clearly. It does assume that it's regular, but if it's not regular, then I would do this maths for the largest gap and the smallest gap and just say an irregular rhythm ranging from X to Y. You can just have a look at it and sometimes you can just tell, okay, is this a bradyarrhythmia? Is this a tachyarrhythmia? But you should still work out the exact rate. So causes of a tachycardia, they can be completely normal. So if you're exercising, your heart rate's going to go up. If you're unwell or if you're pregnant, your heart rate will go up. Some pathological reasons for a heart rate to go up would be anemia, PEs or thyrotoxicosis, or just, a step before thyrotoxicosis being hyperthyroidism. And causes of bradycardia are pretty much the opposite. So if you go from doing heaps of stuff while you're exercising to doing nothing and sleeping, your heart rate will go quite low. And if you're hypothermic. But some pathological causes would be if you're having a heart attack, or if you're on medications, or you have a low thyroid. So if we do some examples of what the rate is. So this one up the top, if we have a look, there's sort of 1, 2, 3, 4 and a half. There's only 4 there. So if we just assume it's 4, we're going to do 300 divided by 4, which, despite my bad maths on the other page, we're all going to know that that is 75. So 4 large boxes, 300 divided by 4, 75 beats per minute. This one here looks like 3 pretty much throughout. You can get a little bit of variation in the rate with breathing. So if you guys have ever timed your pulse and taken a big long breath in and a big long breath out, if you're very vagal, which I've been told I am, then your heart rate will increase with your inspiration, and it will decrease with your expiration. This is such an aside, but it's kind of interesting. And that's just because of how when you inhale, there's negative pressure. And so not only does air get sucked in, but your blood gets sucked into your heart as well, which makes it pump faster. And the opposite's true for expiration. So there can be a little bit of variation in normal people, and that's more common in young people to have that respiratory changes. So this one, back to the issue, we said was 3. So 3 large boxes. So 300 divided by 3 is 100 beats per minute. And this is where you can see that you can get some of the sort of almost looks like a saddle shape, but it's not pathognomonic saddle shape. And that's just because the P wave and the T wave are starting to get quite close, and sometimes they can get hidden beneath each other. This last one down the bottom, if you use the eyeball method, you can see this is pretty slow. So we're looking at sort of, there's a half here, but 1, 2, 3, 4. Oh no, I can't count. 1, 2, 3, 4, 5, 6, 7. If we push that one in and push that one over a little bit, so maybe 7.5 between them, 7, which I think makes it around 40. Yeah. So you can say 7.5, and if you know what 6 is and you know what 7 is, then 7 and 8. then you can just pick a number in between there. So hopefully you guys were all fine with that. Okay, so I don't know what happened or what you guys heard or what got cut off, but the paper method is when you just mark a few of the R waves and then move that piece of paper along. Sometimes it doesn't exactly match, and you might have a bit that matches and a bit that doesn't, but you should be able to see if it's really quite irregular. And otherwise, if it's on a computer, I don't know how to help you. I was pretty much all paper for the first half of my year. I'm sure that in emergency departments they'll probably still print them off, and they'll print them off to teach you, and they will definitely print them off for your OSCEs as well. But otherwise there might be a little ruler tool from memory. So yes, good luck with that. So you have to now ask yourself, is this sinus? Sinus rhythm has a P wave, and for every one P wave there is one QRS complex, and the QRS complex is narrow. And if it's not sinus, so it doesn't really fill this criteria, then we're going to ask ourselves a few other questions. So if the P waves are absent, it's pretty much AF until we've worked out otherwise. And something that might be confusing that someone in the lecture asked me is the difference between this part here, so P waves absent, and here, plus a narrow QRS. And so I've said here that it's above the ventricles, and it's called a supraventricular tachycardia. So even though that is quite confusing, it's because AF is a type of supraventricular tachycardia. So they're sort of the same here. If the P wave is absent, but the QRS complex is broad, then you're looking at a ventricular issue. So this might be a ventricular tachycardia, VT, or ventricular fibrillation, VF. If it looks like sawtooth, then it could be atrial flutter. And if there isn't really any clear connection between the P wave and the QRS, then we should probably have a look at AV conduction blocks. So this is about axis. So this is going to be hard to explain when I can't show you guys my thumbs, but the most common way to work out axis is with your thumbs. So, sorry, excuse me one sec. So a normal axis, and I think this picture probably describes it quite well, but a normal axis means that the depolarization through the ventricles is occurring pretty much down the septum, and it's occurring equally, like that, like the slide I showed you at the start. But if there's a thicker left ventricle, then you might have a left axis deviation, and there are some other causes. And if you have a thicker right ventricle, then you might have a right axis deviation. And as we can see here, so this is what the normal ECGs look like, and I suppose the total, an axis is looking at the total of all of the depolarization, which I hope that makes sense, and just looking on mass, on net, where is the energy moving. So from here, it's moving this way, but if you have a right axis deviation, it's moving towards the right, and if it's left, it's moving towards the left. And you can see the corresponding ECG changes here, which I've also listed here. So in a left axis deviation, lead 1 will be slightly positive, and lead 2 and lead 3 will pretty much be negative. And I think the opposite is true for a right axis. So lead 3 will be positive and lead 1 will be negative. So I think the thumb or the diamond method is the most common. So your left thumb is lead 1, and that always goes on the top. because it's right to be left. No, oh, that's confusing. Sorry. I don't know how you remember that, but I hope you will. So your left thumb is up the top and it's lead 1. And your left thumb is down the bottom and it's lead 2. Or some people use lead 3, and it doesn't really matter. Maybe look at both of them for completion's sake, I suppose. So if you are pointing, if both lead 1 and lead 2 are positive, you've got both of your thumbs up, so you're all good. That's a normal axis. If your lead 1, so your left thumb, is pointing up towards the roof, and your right thumb, being lead 2, is pointing down towards the floor, they're pointing away from each other, which means they've left each other. And that's your left axis deviation. If your lead 1 is pointing down towards the ground, and it's up on the, it's higher, and lead 2 is pointing up and it's lower than your left hand, then they're pointing towards each other and they're right for each other. So it's a right axis deviation. I hope that makes sense. I'm standing here gesturing it, but I know none of you can see me. If you have any questions about it, just shoot us a message or post on the group or whatever you would like, and we'll try and help you out. Otherwise, technically speaking, some people might show you these images. You can work it out based on, that sort of circle image that I was showing you at the start. You can put all of the segments together and work out where it is. A lot of people will try to tell you that this is a normal axis in here. So you can see that color. So this is a normal axis. Then they say this part here is left, and then this is right, and this is technically no man's land because it's heading backwards. And if you imagine your heart sitting in here, then this is the normal transit. Otherwise, it's a left or a right. So it sort of makes sense, and a lot of people will try to explain it this way. But I think it is quite complex. So a few practices. So if we have a look at lead 1, it's pretty much negative. The majority of the QRS complex is below the isoelectric line. So this lead 1 is pointing down because it's negative. And that's our left hand, which is higher in the air than our right. And if we look at lead 2 and lead 3, they're both positive. So our right thumb is going to be pointing up. And given they're pointing towards each other, they're right for each other, and that's a right axis deviation. This one, process of elimination, there's pretty much only 3 axes. I mean, I hope there's only 3 axes. Lead 1 is positive, so your left hand is pointing in the air, and lead 2 and lead 3 are both negative, so your right hand, is pointing to the ground, and they are leaving each other. So lead 1, positive, thumbs up. Lead 3 or lead 2 is negative, thumbs down, and it's a left axis deviation. So this P waves. So we've moved on, we've done our rate, we've done our rhythm, we've done our axis, and now we're at the start of our QRS, at the start of our little complex, which is good. We're advancing. So if your P wave is present, you're pretty much in sinus, and sinus just being you're being driven by your SA node. If it's absent, it's essentially atrial fibrillation. And the definition of that being irregular rhythm with absent P waves. And we'll cover this later. If there's lots of kind of what looks like P waves, and they're quite regular, so they look the same, then it's atrial flutter. If it doesn't look like they're talking to each other, it's probably AV conduction block. And if they look funny, then it could be these 2 things. So this one here is our P pulmonale. So it's really a lot taller than normal, and more than 2 small squares high. And it makes a part of cor pulmonale. So cor pulmonale is essentially a complication of any pulmonary issue, and it's usually late stage. And it essentially results in right atrium hypertrophy. So if you've got high blood pressure in your pulmonary system, that can cause it, or any right-sided valve issues. So if we have a look over here, so this is our normal ECG. So we've got a nice P wave, which is in the blue. Okay, so this is our P wave, and the red here is our right atrium. I'm so sorry. So given the SA node sits in the sort of top pocket of the right atrium, the depolarization is going to move through the right atrium first. Then, I think it's, I can't remember what the bundle's called, sorry. But it moves across to the left atrium. And then it depolarizes. And they happen pretty similarly. So it takes a little while to get to the left side. So it's going to take a little bit longer to depolarize. But it's pretty smooth. And that gives us our nice P wave. Okay? So, in P pulmonale, we've got right-sided issues. So our right, which is our red, is thick with like 7 C's. And what happens is, because it's so thick, it takes a lot longer to depolarize. So now the right and the left are depolarizing at essentially the same time, which adds together and gives us this huge P wave. On the other hand, we have something called P mitrale, and you get this notching, which is kind of good because it looks like an M, and it's mitrale. And what happens here is it's because of left-sided issues, and it makes the left side thicker than the right. Ooh. And what happens is, if there's more muscle there and it's thicker and a bit more scarred, then it will take longer to depolarize. So now your right side's working perfectly, but your left side is slowed down. And then because they separate and the left pushes out, you get an M shape. Okay? Go over that a few times, but it should, so is a little bit easier to and then the top tip up the top is that if you have a look at V1, which I sort of mentioned before, it's on the right hand side of the sternum. It gives you a pretty good look at the P wave, so if you're not sure. And in the next slide, I'll show you how different the P waves in lead 2, which is your like bottom main strip, are compared to V1. So, some examples. What do you guys think the one up the top is? So if you have a look at it, it's pretty regular. It's nicely spaced. It's a little bit bigger in the middle here, but that can be normal. There's a P wave. It's very closely followed by a QRS, so the PR interval is probably fine, but we haven't got to that, so I'll stop talking about that. But otherwise, it might have been a trick because it's sinus. Looking at the second one here, it's definitely not regular, and it could be quite rapid in some places. So there's only 2 squares in here, which makes it 150, and over in here there's about 1, 2, 3, 4, 5, which makes it down at 60, I think. So it's pretty all over the place, and you can't really make out any P waves. I mean, maybe, but I don't know, it's sort of hard to work out what's happening. So this is lead 2 here. If we have a look at V1, we can see that there are no P waves there. It's just, for a lack of better words, fibrillating. It's atrial fibrillation. If we have a look here, and this is a nice one to contrast, because sometimes you can convince yourself, are these flutter waves? But here you can see that it really looks like a sawtooth, and it's harder to miss. It's regular, and it's pretty much a 3-to-1 the whole time, so 3 flutter waves to 1 QRS. And I call them flutter waves. They are called flutter waves instead of P waves at this point. So they are sometimes denoted as F waves. So this is our atrial flutter. If we have a look here, there's sort of a notching to our P wave, and it looks a bit like an M. So this is P mitrale. And this one here looks a bit scary, I'll be honest with you, because it's almost like, oh, is this a P wave here? And actually, no, that couldn't work, but it just looks a little bit messed up. But that's because your P waves are quite tented, or not tented, tall, and that's P pulmonale. All right, moving on to our PR interval. The PR interval, as we sort of explained at this, as I explained at the start, is how long it takes the conduction to move through the AV node, essentially. And if it takes a long time, then it's a conduction block. So you pretty much count it. In first degree heart block, it's slightly harder to pick up because you actually have to look at how long the PR interval is. But when you look at second degree heart block and you have dropping of QRS complexes, you sort of, in my experience, you see the drop first and then you go back and look at the PR intervals. But it's always a good habit to look into it, because someone who has a first degree heart block, we should really monitor for any progression. Okay? So you pretty much just count them. 3 to 5 is normal. I imagine if it's too short, that would be bad as well, but I don't know anything beyond that. So your first degree heart block is just a PR interval longer than the 5 small squares. So every QRS complex has a P wave before it, but the PR interval is just a little bit longer. There are some causes here, but for the most part, this pretty much looks like, actually the example here is quite obvious. It's not very zoomed in, but I think there's a P wave here, which is quite long. But if it's a more subtle one, it can look very similar to a sinus rhythm, and like a completely normal sinus rhythm. So your second degree heart blocks have 2 types. So your Mobitz type 1, which is Wenckebach, and Mobitz type 2, which is not Wenckebach. So your Mobitz type 1 is when your PR interval is getting longer and longer and longer, and then it will drop a QRS. So one of your P waves goes to the AV node, but doesn't keep going through. And then it'll return afterwards. And it repeats that in a cycle. So Mobitz type 2 is when you have a long, but I suppose stable probably isn't a good word, but constant PR interval, and then it will just have non-conducted P waves. So as I said, there's a P wave up the top of the of the atria that goes to the AV node, and the AV node just says you're not getting through. So you go without a QRS and without a ventricular contraction. So I think we've got type 1 over here, so our Wenckebach, and you can see that they've timed it out, so it's getting a bit longer, and then there's a P without a QRS. And so as I said, you can pretty quickly, maybe more so here, but you can see that, there's a big gap here and everything else is regular, and then you look back at the PR interval. All right. Third degree heart block, it's also called complete heart block. It's when your atria contract normally, but it doesn't get through to the ventricles, and then just below the AV node, at the bundle of His is where your next conduction will generally come from if it's narrow, which I've written here. So you have the top of the heart, the atria, doing what they want to do, and the bottom of the heart doing whatever it wants to do. So sometimes you can start off and say, okay, that sort of looks normal, and then you get a bit further on, you go, oh, this is not quite right. But you will be able to tell that the P waves will all be regular and the QRS waves will all be regular, but they're just not synced. And if they're narrow, then it means it's coming from higher in the heart. And if it's more broad, it means it's from lower. So they can get down to the Purkinje fibers, which would be quite slow. And this is probably a time where you'll realize that every ventricular contraction gives you a pulse. So your heart rate and your pulse rate are not always the same. And there are some causes here. And it's sort of usually ischemia related and just with fibrosis. So sometimes you just, over time, you get scarring from either heart attacks or just chronic ischemic heart disease. All right, so we're going through this one. If we have a look at it, there's a P wave out here, QRS, T, P, so it looks pretty normal. There's a bit of a gap here, and actually if we have a look, there's a P wave and a P wave there. So this is wank back the DJ. So a good way to remember it is they build the tension, so it's shorter, and then it gets longer and longer and longer as you're building, and then it just drops. So they drop the bass. And this is your second degree AV block, Mobitz type 1, which is the wanky back. So this is it getting longer, and then it just drops. So looking at this one here, we've got a P wave, QRS T, P, QRS T, P, and then a QRS, but it doesn't, I mean, this sort of before it, but not really. And then that's probably a P there, another one there, probably one hidden in there, and one at the start. So it looks like we've got, and if we mapped it out, and that's quite tented, so there's probably one in there. The P waves are probably regular. The QRS waves look pretty regular, but they're just not talking to each other. So these are where all our P waves are, and they're all our QRS. So still regular, not talking to each other, which is a complete AV block. This one here. So this is what I was saying. It's hard if they don't drop a QRS complex. But in the setting of this lecture and what topic we're on currently, all of the PR intervals are just a little bit long, which I think that would be hard for me to find as well, to be honest. Alas, that's what it is. It's a first degree AV block. And then looking at this one and also the process of elimination, it's pretty much the same length, and then it just drops one, which is our second degree Mobitz type 2. And there's just some highlighting. So moving down to the QRS complex, it's good to work out, is this a narrow QRS complex or is this broad complex? And if it's narrow, it means that there isn't an issue in the ventricles. It's above the ventricles. And that's called supraventricular. And if it's fast, then it'll be tachycardia. If your QRS complexes are narrow, so there's not really an issue in the ventricles, but they're quite small, it can mean that the heart is surrounded by blood or fluid. And it can also mean that people are a bit larger. So there's more tissue to have to move through, either tissue or fluid. The ones I've underlined here are important ones to know and be able to distinguish, which AF and atrial flutter I'm sure you guys would be good at. AV conduction blocks as well, you'll get there for them. The AVNRT and the AVRT, there's only one particular type that you need to know out of them, in my opinion. But having a brief idea of what these are is also good. In terms of if it's broad complex, if it's broad, essentially it's an issue in the ventricular conduction system. So it's quite low in the heart. If it's fast, it's pretty much one of these things. So it's either ventricular tachycardia, ventricular fibrillation, or ventricular ectopics, which I'll go through later. And if it's slow, then it's a bundle branch block. In the QRS complex, there's meant to be a gradual progression from mainly negative to pretty much positive. So V1 should be negative, and then V3 should be the transition point. So here where it's pretty much isoelectric. And then at V4 or 5 is where it should be the highest. So if you get a right ventricular hypertrophy, you don't get that proper transition point like here. And it shifts and moves along. I honestly would never be able to pick this. I technically say I'm just looking at the R wave progression, but I never really do it, and I didn't really know what to look for, so I think you can get away with it. One thing that would be important to know is if your R wave is really quite high, and there's technically a mathematical equation to work it out. So if you have QRS, so working out how deep this is, that this one here, how tall your biggest R wave is, and so you look in certain leads, and if that's over 35 millimeters, then it's left ventricular hypertrophy. But if you guys were ever shown one, it would look huge. Like the spikes are just like they're running into each other. It's quite clear, the clear-cut ones. A pathological Q wave. So this portion here, so if we imagine you've got your P, PR, then you go down for your Q, R, S. You can see here that the Q is quite deep. So normally it just comes down one small square. If your Q wave is more than half of your R wave, so this one pretty much is, then it's indicative that there's scarring there. So you should be able to see this Q wave in either the inferior leads or the anterior leads, depending on where the old heart attack was. So that's sometimes quite useful to pick up on. And then if the patient can't tell you anything, you know that they have had a heart attack before, or if they've presented and said, I had an episode 6 weeks ago, do you know what it was? And maybe this is what it was. So our bundle branch blocks are when we're looking at the QRS complex as well. A left bundle branch block, if you have an ECG that has a new left bundle branch block, and most people will be told, if someone finds it, they'll say, so I've found that you have a left bundle branch block. This isn't really anything. But if they don't know that they had one, you should treat it as a heart attack. So there are some other causes such as cardiomyopathy, high blood pressure, or aortic stenosis. But yes, just be wary that a new left bundle branch block could be a heart attack. And what you're looking for, so this is from Ben Amberg. You can sort of see, it's quite small, but the left side has been cut off. So you need to go all the way to the right and then go across. And if you imagine this dotted line is coming towards you and more ventral in the chest, and it's going across to the left side. And that's why you sort of get a strange deflection, because it's going away and then sort of towards. And that's the physics of it, which again, sorry if you don't want to hear that. So you're looking for a W shape in the QRS in V1, which is technically called an RS, so the R being little. And then you're looking for an M morphology, and that makes your William with the L's in the middle indicating left. And the opposite is true for the right. So a right bundle branch can be more normal. Otherwise, it's right-sided issues. And if you have pacing wires, they usually put the pacing wires in the left, and they will stimulate the heart prior to normal conduction. And so it will have this same effect. It will stimulate them here, and then it will go across to the right in this mechanism. So looking for an M in V1 and a W in V6. So some examples. So if we have a look here, this one is a hard example, to be honest. But you can see that there's V1 to 3. It's not normal. You can see quite a clear. So there's a little peak up, then the middle of the M, and then that. So this is probably going to be a right bundle branch block, but it is hard to see the W here. There should be an extra notch in the middle of this R wave. So it should go up for an R, then down for a little bit of an S, and then back up for an R. But it's hard to see. Technically speaking, you need to have a wide complex and you need to see it in V1 and V6. But some people would look at this, and I think I got this off Life in the Fast Lane. So they've clearly classified it as a bundle branch block. So some people would consider this, other people would need the V6 changes. Otherwise, you've got the M in V1 and a bit of a W. I mean, maybe not, but in V6, and it's wide in these ones as well. Given you've got an M at the start and a W at the end, it's going to be the right bundle branch block. So there we are. For this one, also process of elimination, but this one's a bit easier to see. You can see that it's flat on the top, and that's going to tell you that there's some sort of notching in there. It's not just up with a straight tip. And then the same in V6, there's sort of an M shape there. So if we've got a W in V1 and in V6 we have an M, and they're pretty damn wide, to be honest, then we're looking at a William, which makes it a left bundle branch block. Our magic number being 3, so it should be less than 3 small squares, and it should be at the same level as the PR interval on the other side of the QRS. And we would only accept less than 1 small square in L1 to 3 and 2 in the V leads. So it has to be less than that. And so, yes, sorry, I just had a mental lapse. So if you're looking at the ST segment and it looks like it's elevated, you need to work out if it's more than 1 small square in the limb leads, which are your leads 1 to 3, and your augmented leads, or if it's more than 2 in the chest leads. And the way I think about this is that if you are closer to the source, you can be more specific about what's happening. So small changes will be detected better. And so you need to have bigger changes for it to be, for us to be happy with it. Whereas if you imagine how far the limb leads are from your heart, if you're detecting it in your limb leads, then it's really happening. So that's the way I like to think of it, because I always struggle to remember, is it 2 in the limbs, 2 in the chest? But closer to the heart, you want to see more of a change. Whereas all the way out the limbs, if you're seeing a little bit of a change, then it must be pretty big at the heart. An infarction is localizing to area of infarction informs likely artery. So you need to have a look at where the distribution is. If you have global ST elevation, then it's probably pericarditis. Please, 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 if you ever see some ST elevation, just make sure that you glance at the rest of it. Even if you're pretty sure it's inferior, just make sure it's not everywhere, because the treatment for a pericarditis versus an ischemic event will be very different. You can get ST depression, where you're looking for more than 1 small square of depression, which will probably be very similar about how much you're looking for in the chest versus the arms. But that can be a sign of early ischemia or a non-STEMI, or it can be a reciprocal change. So if you have a posterior AMI or STEMI, then you will see some anterior depression. If there's saddle shaping to the ST segment, it can be pericarditis as well, or a tamponade. And if you see here how it's going backwards, the ST segment, so it's depressed, but it's sort of in a reverse tick, that's digoxin toxicity. So digoxin being a common, I think it's a drug that people who have heart failure and atrial fibrillation can take. And something that my colleague Alex pointed out was that in digoxin toxicity, people will complain of yellowing eyes. So there's a little yellow dot there. Look, inferior. Oh, it's not right. Right coronary artery. Okay, well, I've also got some revising to do. Let's go right. I don't believe it's irreversible. And when you have ischemia, you'll get the ST depression and the T-wave inversion. So this would be your non-STEMI. And as I said, okay, so you need one small square in the chest, but you can have half in the limb lead. And one important thing to take away is they need to be in two what's called contiguous leads. So essentially you need two within the same like inferior distribution, lateral distribution to be able to call it an ischemia. For an infarction, you're going to have ST elevation, Q waves later when it's dead. And as I said, you need more of a change in the chest leads, less of a change in the limb leads, and they need to be in two contiguous leads. So two that are next to each other. The QT interval, so as I said, it should be less than half of the R to R interval. So around 11 small squares. So the T wave should be a little bit closer to the QRS than it is here. And there are various reasons for a QT syndrome. So many of them are congenital. Otherwise, if you take medications, and commonly psychiatric medications. So a lot of people who are on psychiatric drugs will need to have ECGs as part of their monitoring to make sure that they're not having any effects there. And the reason why we care so much about long QT syndrome is because of the risk of ventricular tachycardias and fibrillation, which would be our pretty much our big major concern about what might happen if you have one of these. And so the treatment will essentially be stopping these medications. U waves, as a fun little tidbit that I came across, the slower your heart goes, the more likely you are to have a U wave. And in a pathological setting, it's essentially hypokalemia for our level, but there are a lot of other causes. So Ben Amberg, I hope you all have a copy of his notes. They are positively excessive, but he does go through a lot of things that other people don't, and he tends to have good flowcharts for things, and good classification systems, and I like his notes for hematology as well. But for arrhythmia, he says look at the rate. So you're going to work out if it's fast or slow, because that's really going to determine what you're looking at. If it's fast, you need to work out if the QRS complex is narrow or broad. And as I've said, if it's narrow, it means it's above the ventricles, and broad, it means it's a ventricular issue. And from there, you can work out what's happening. And the same for bradycardias. So if we go through the slow heart rates, these are some of them. So, I've written that wrong. These are all the tachyarrhythmias. No, these are all the bradyarrhythmias that literally pretty much exist, but we don't need to know them all. And a good thing, I suppose, about this topic is that bradyarrhythmias will present pretty much the same way. If your heart is too slow, you are not getting blood out. So you will faint. You will feel dizzy, you will feel sweaty, you will look pale, and you will be confused. And commonly what happens is old people will have these episodes, they'll get an ECG and you'll see that their heart is just so slow, and they'll commonly get a pacemaker for that. So a sinus bradycardia can be physiological, so in athletes, or if you're really cold, or if you've given you meds. Otherwise it can be pathological, which are pretty much all of those causes I listed before. You need to investigate why it's happening. So are their electrolytes off? Have they had a heart attack? And the management, if someone's essentially passed out in front of you, you need to do doctor's ABCD, which is by far the best thing to say at the start of pretty much any OSCE. You need to maintain the airways, give oxygen if they need it, give atropine, and then you can do external pacing. So this is just where you essentially put a pacemaker on them, but from the outside. And you can have, this is what I was talking about before with the respiratory sinus arrhythmia. So this is where your respiration will affect your heart rate. So if you have good vagal tone, then you will be better at this. And it's kind of fun. Sick sinus syndrome is where your SA node is just a little bit dodgy, and it can essentially cause, as I've outlined here, it can cause fast and slow heart rates, which is a type of sick sinus syndrome. It mainly happens from degeneration and fibrosis over time, but there are some drugs that can do it. Sometimes it might be that when you're exercising, you don't experience your heart rate getting any faster. And with all of these, an ECG will tell you what's happening. If there's a cause, reverse it. If they're asymptomatic, you can just do some follow-up. And if they are symptomatic, then it's the same as the sinus bradycardia we had before. You can get little periods where your heart stops, and it can happen in healthy people, but mainly in sick sinus syndrome. And this is where they might collapse because they're not getting any output for half a minute. And on ECG, you'll see that they don't have any P waves, and so they'll then revert to quite a slow rhythm. And I mentioned about the tachybrady syndrome. So the heart blocks we went through, these are, so anything that damages the conduction pathway can cause one of these. So infiltrative diseases, so Alex went through this a bit, but if you have sarcoidosis or amyloidosis, then you can get infiltration of the conduction system, and it essentially doesn't work anymore. Otherwise, infective endocarditis is a common cause of atrioventricular blocks, as well as medications. So we went through first degree, which can happen with vagal tone. We know about Mobitz type 1 and Mobitz type 2, and again, just fibrosis, or you can have a right coronary artery infarction. Third degree, as a buzzword, it's associated with Canon A waves in the JVP. I'll be doing a murmur talk potentially next week on the, I don't know what date it will be, but I will be doing that, and hopefully we'll get it recorded as well, but I'll go through all of the JVPs. And for a third degree heart block, this is not very conducive with living, so we need to get a permanent pacemaker there as soon as possible, which is the ppm here. So for all of them, if they're asymptomatic, you can just monitor it and address the complications as they occur. If they're on a beta blocker, good to stop it, etc. If there's any reversible causes, we should address that. Otherwise, if they're symptomatic and they're hemodynamically stable, so their heart rate's okay, their blood pressure is stable, then we can just monitor them. And if they're hemodynamically unstable, then again, we go back to sinus bradycardia, which is essentially atropine and a pacemaker. So I hope you guys are getting the picture that for bradycardias, it's atropine and a pacemaker. All right. Bundle branch blocks. So this is what I was explaining before about your right and left. So on your right side, you've just got this, and on the left side, you've got a posterior and an anterior fascicle. So you can just get one of these blocked, either the right or the left anterior or the left posterior. The right bundle branch block will show how we worked it out before. So it'll come up as a M in V1 and a W in V6. Otherwise, your left anterior hemiblock, which would be this big boy, is a left axis deviation, and otherwise your left posterior hemiblock will give a right axis deviation. You can also get a combination of the right bundle branch plus one of these two, and they are called, that's these. So you'll either get a right bundle branch block with a right or a left axis deviation, which is a combination of the ones up here, or you can get a left bundle branch block, which is technically bifascicular because it involves the left and the right, the anterior and the posterior fascicles. And you can also get a trifascicular block, which is also known as bad news. So that's when you get your right bundle branch block and left quite high, given it's going to block off the anterior and the posterior. Sometimes they're incomplete, and sometimes you'll get like similar to a 3-to-1 or a 2-to-1, where some will be conducted through, or it can present as a bifascicular block like this, and occasionally will have some issues, or it can present as a complete block. All right, so that's essentially everything you needed to know. The last 2 slides about the AV blocks and the bundle branch blocks are the most important. The other ones are sort of for your reference in the future if you're interested. So atrial tachyarrhythmias are faster than 100 beats per minute. So again, these are pretty much all of them, but know the ones in bold. So the common symptoms to atrial tachyarrhythmias will be tachycardia as a sign. They can be quite short of breath and quite sweaty. They can be just tired ongoing, and they might have some chest pains as well as passing out. So if your heart's going too slow or too fast, you're not going to be getting that cardiac output that you really need. All right, so sinus tachycardia, which is just a rate above 100, and there's particular ranges for children and infants, but they're just higher than 100 as well. And the P wave will be present for a sinus tachycardia. So there are lots of causes. So it can be due to pain, anxiety, or as we mentioned, pregnancy. Otherwise, physiological causes if you have sepsis, hyperthyroidism, if you're in heart failure or you have a PE, or pharmacological causes. So beta agonist, and a common one of a beta agonist, which I quizzed you guys in class about, and I hope you all know what the class of medication is, what the drug name is, and what the brand name is, just for this one because it's quite easy. But a common beta agonist is a short-acting beta agonist called salbutamol, also known as Ventolin. So if you guys have ever had that, people get really fast heart rates and they start shaking, and that's part of that is because their heart's going so fast. Sympathomimetics, so something that's essentially acts like your sympathetic nervous system, which is obviously your fight or flight, and antimuscarinics and caffeine. So when you're examining these patients, you'll come across a tachycardia, but they might have palpitations and they might have shortness of breath, but also making sure that you look for an underlying cause. So are they pale? Do they have anemia? Is there a lig lag, or are they clammy, which might suggest thyroid issues? Or do they have orthostatic hypotension, which I think I was getting at diabetes, but I can't remember now. And I think this is one of the important things to take away from 3B, is that in first year you're trying to detect what someone has, and in third year you really need to work out why they have it. So working out, okay, I think a common one that I like to talk about is anemia. So anemia, in my opinion, is not a diagnosis. You don't just have anemia. You have anemia as the outcome of something else. Maybe you have celiac disease, maybe you have, maybe you're vegetarian, but you don't finish your investigations at you have anemia. You need to work out why, as another aside. So managing tachycardia, you can reverse the cause, so infection or managing hyperthyroidism. And otherwise you can give medications, which is metoprolol, or any other beta blocker. And just for metoprolol, it's given 25 milligrams twice a day. So you guys will start to get familiar with the names. So always looking at the end of the name, which I'm sure you all know. And then BD just means twice a day. Otherwise, calcium channel blockers can be used. Atrial tachycardias. So the difference between an atrial tachycardia and a sinus tachycardia is that this comes from within the atria, but not necessarily in the SA node, whereas sinus tachycardias come from the SA node. So atrial tachycardias include atrial flutter and a fast heart rate because there's lots of different foci within the atria. So what happens is you get circuits that start to self-activate, and it causes a lot of activity, and then they essentially become self-sufficient. So this can be because of too much digoxin, which I hope you guys are quizzing yourselves on. What do we see in the ST segment? We see a reverse tic. And what do people complain of in their vision? Yellowing vision. So this can also come from atrial scarring. It can be idiopathic, or it can be from stimulants as well. And usually this is an abrupt onset, and then they'll have the similar symptoms that we talked about at the start. So they might be quite dizzy, or they might even faint. And looking at the ECG, we can see that there's a lot of P waves. So if there's lots of different foci, then there'll be lots of P waves. But if there's one, then it will be different. And if it's say in the left ventricle, then it'll give a different picture to whether or not it's in the right ventricle, which is atria, which is normal to be in the right. The QRS should look normal, and sometimes the baseline can sort of be a little bit funny. And sometimes you can go into heart failure because of having a heart rate too high. Atrial flutter. So this is, in terms of the risk factors and most of the symptoms and the investigations, it's very similar to atrial fibrillation, which we'll go through. So it's a type of supraventricular tachycardia. It's rapid and regular, and it's because of a re-entry circuit in the right atrium, which is different to atrial fibrillation, which is on the left atrium. It happens in males more than females, and there are an abundance of causes. Essentially anything that messes with your right atrium, or your heart for that matter, can cause atrial flutter. So what happens is you get a re-entry circuit, so that's where it starts to become quite self-sufficient around your tricuspid valve, and this just gets faster and just is self-sufficient and will continue to stimulate itself and will happen regularly. So you'll get a number of them, and then occasionally it'll go through the QRS complex, and that's why you get that classic 3-to-1, 2-to-1 sort of ratios. So it can be asymptomatic, otherwise people will complain of palpitations, fainting, all the other things. So investigating it, you'll do an ECG, and you can also do an echo, which I'll explain a bit more in atrial fibrillation. The complications is if you go into 1-to-1 conduction, your atria is asking your ventricles to go at the same rate as them, and your atria can go at a max 300, and your ventricular rate will not like going at 300, and that's essentially when you've got ventricular tachycardia and you're very at risk of death. So if we have a look at this ECG, we can really see those flutter waves that we were talking about. So this one's quite a low conduction rate. So if we look at, you're almost looking at 8 or 9 large boxes in between there. So this is quite a slow example, although it does have some faster portions here. But in general, it's going to be rapid and irregular, but it'll be in a fixed pattern, so the 2-to-1, 3-to-1. And you'll have an atrial rate of around 250 to 300, so that's all of these F waves. And then the ventricular rate will be less than 200. So this one here is particularly slow, but they can get quite fast. And as I said, the F waves are the sawtooth waves, and you can see them best in 2, 3, and AVF, so in those inferior leads. I don't know I couldn't tell you if that's in general or if that's just for this ECG. Give it a go next time you see atrial flutter. So as I said, a 1-to-1 gives you a beat rate of 300, which is life-threatening, but otherwise a 2-to-1 will be 150, etc. So managing this, so what you want to do is you want to increase vagal tone. Your vagal nerve is part of your parasympathetic nervous system and will decrease your heart rate. So what you can do is you can massage the carotid body. This will tell the carotid body that the blood pressure is high, and so it should decrease heart rate to compensate. The good thing about these is we can start, they're non-invasive. Even if you just try it for a little while, it might work and you might save a whole host of sort of rather invasive issues later on. Otherwise you can, I couldn't actually tell you how the cold water works. Maybe you dunk their face in it. I can't quite remember. Or their feet. I don't know. Maybe their whole body. I still don't know. Valsalva is a good one to do. So you can say, I know Marianne used to say, try to breathe out on a closed epiglottis, which I don't think many patients would understand. But asking them, if you guys know, I'm sure you know what a syringe looks like. If you ask the patient to blow in the small end and try and push that the driver out the other side, that's a good one, because it has a goal attached and it sort of makes a bit more sense. Otherwise, sort of asking them to strain, I suppose, could work. Or, yeah, I don't know what else you could say. I like the syringe one. You can do rate control, which is with cardioselective beta blockers, or you can do rhythm control, which is with a non-cardioselective beta blocker, which is sotalol, which is an antiarrhythmic medication. You should also consider anticoagulating them. So because there isn't that coordinated contraction, you get pockets in the atria and you get turbulent flow, so you're at risk of clotting. So we do the CHADS-VAS to work out if they should be anticoagulated, and then we can either give them warfarin or DOACs, so direct acting oral anticoagulants, which is the opposite way around to how I've written it. I think I've always written it that way, and I'm just realizing. For DC cardioversion, if you're within 48 hours of onset, the theory goes that they kind of formed a clot by then, so you can cardiovert them if they are hemodynamically unstable. What this means is you apply a shock to the person and you try and reset their heart. In the long term, they can ablate and essentially burn those the macro entry pathways and stop that from happening. And it's easier for this than it is for atrial fibrillation because it's right-sided. So you generally go through the femoral artery and feed it all the way back up. No, wait, that doesn't work. I don't know. It's easier. Oh, you must go in a vein. That makes more sense. And far less risk. So you would go on a vein and then thread it back. I hope that makes sense. Sorry. We'll go through atrial fibrillation again because it is very important, and given the incidence of hypertension, it is increasing, to be honest. So it's the most common sustained arrhythmia, and it's due to uncoordinated atrial activation, and it causes an irregular ventricular response. So essentially what that means is the atria aren't effective and the ventricles are just, they're doing what they're told, and what they're being told is rubbish. So it's present in 1 to 2% of the population, and 95% of the people with atrial fibrillation are older than 65. A good mnemonic for remembering the causes of atrial fibrillation is pirates. So you guys can read that there. Thyroid disease is a common one to know. But pulmonary embolism is a good one to remember as well. And high blood pressure in the long term causes remodeling, and that's how it leads to atrial fibrillation. And every cardiovascular risk factor is a risk factor for atrial fibrillation. So on history, patients can be asymptomatic. Otherwise, they might feel like their heart's skipping a beat, and you can ask them to tap out the beat that they feel in their chest, and usually from that you can tell that it's irregular. Otherwise, just listen to their heart. They might feel dizzy, and they might have some shortness of breath. You do need to look for the underlying cause. So is it thyroid? Is it anemia? Is it a PE? Assess their risk. So you need to ask questions according to CHADS-VASc, so you can complete that later. If you ever get an OSCE where they have palpitations, write down CHADS-VASc and make sure you ask those questions in the OSCE. it's not the end of the world if they say, please work out the Chad's Vasc, and you say, oh, I don't know if she has heart failure, I don't know if she's had an event before, but you look slick as if you have asked those questions. And also asking about complications. I think there's an OSCE going around where they have palpitations and you need to ask if they've had any similar or related events, and you sort of work out that actually they have had what sounds like a TIA in the past. And so patients might not come in for a TIA because it's short-lived and they just think it'll go away, it's fine. And then you realize, well, actually they might have had atrial fibrillation for a lot longer. And if they've had a TIA, they're at much higher risk of having a stroke. So that's also a way that you can look very slick and like you know what you're doing. So in your history, you can really show to the person, to the examiner, or just to yourself, I suppose, that you know the symptoms, you know the causes, and you know what to do next. And I think that's, if you guys can do that by the end of 3B, then like pat yourselves on the back, because I think in terms of a clinical participant, and I think as a young doctor, that's a good thing to be able to do, let alone to be able to do that for an OSCE. On examination, you need to work out if they're stable or not. You should feel an irregular pulse rate. If it is atrial fibrillation, they might have mitral stenosis as a cause. And looking at their JVP, they'll lose their A wave. So the A wave is related to the contraction of the atria, and because that's not happening, you're not going to see that wave. And then also looking for any signs of complications. So does their limb look ischemic? Do they have signs of acute pulmonary edema, so bibasal crepitations? Do they have fluid on their legs? Do they have, a facial droop, or they're not using their arms or the legs, or they can't see anymore? Those things should be relatively apparent, but you can make a note of it. So investigations, it's pretty much the kitchen sink, which is what I've written here. So you want to do an ECG, and you're essentially trying to find out every reason why this has happened. So was it because of a PE, which is your D dimer? Is it because of heart failure? Is it because of thyroid issues? Is it because of alcohol or digoxin poisoning? And coagulation studies are going to help you if you need to cardiovert them, or if you're going to put them on medications to get a baseline. Urine toxicology, again, for a cause, and a Holter monitor if it sounds like a good story, but you can't catch it. And otherwise an echo. So an echo will be able to tell you if they've had changes to their left atrium that might have caused this, and they can also see if there's any clots in the heart. And if there is, you cannot cardiovert them, because once their heart goes into a normal sinus rhythm, they're at risk of throwing that clot. So looking at this ECG, if you just step back, you can really see that this isoelectric line is all over the place. It's wandering left, right, and center. There's, grouped QRS complexes. Doesn't look very regular. And then again, if you look at V1, it almost looks fluttery, but you can tell there's just no P waves in here. So it's irregularly irregular. There's no P waves. And as I said, it's fibrillating around the isoelectric line. And there's narrow QRS complexes. And unless there's some sort of bundle branch block, it should be narrow if they've just got simple atrial fibrillation. Supraventricular tachycardias. So these are fast heart rates that come from above the bundle of His, but not directly in the atrium. So this is usually from the AV node. It can happen in otherwise healthy people, and you can get paroxysmal SVTs. So this means that people come into and out of them. The two types of them, which are the most important to know for the SVTs, are atrioventricular nodal reentrant tachycardia, which means there are two pathways within the AV node. Otherwise, it's the atrioventricular reciprocating tachycardia, and this is when you get a separate pathway that bypasses all the normal conduction. So I'll go through them. Otherwise, there's an osmosis video that goes through both of them, which is pretty gosh darn good. So going back, I don't think there was anything particularly interesting here, but typically it goes forwards down the slow pathway and then retrograde up the fast pathway. So pretty much, what I said. So it goes down this way and then up here. Goes anti-clockwise, I suppose. And then the signs and symptoms. So it's usually had a sudden onset and a sudden offset, and then it'll stop. It's hard. I find these topics quite hard to wrap my head around, but it has the same sort of tachycardia symptoms, and there can be sort of known triggers. This just goes through what the ECG would look like, but it's essentially just fast with a narrow complex. And if you see that and you don't know what it is, I would be handballing this to cardio. And then looking for any causes. If they're unstable, then you want to cardiovert them, and you can give adenosine. So this is the medication that gives you the feeling like your heart is being stopped, and then it should reset this sort of thing. And if they're stable, you can do the vagal maneuvers like I talked about, so the carotid massage or Valsalva, or apparently you're going to submerge them completely in cold water, whichever suits you, and then you can still do adenosine as well. Chronically, this is what I said. Gosh, I'm good, because it just sounds so scary. So just handball it. Otherwise, you can start medications, but that usually fails. And the last line, and probably the most effective, is just you destroy the pathway. AVRT is similar, but it's not in the AV node. So your AV node is normal, but you've got a different pathway. And in Wolff, Parkinson, White, it's called the bundle of Kent. So what happens is, if you have normal vagal tone, it slows down the AV node, but you've got a second pathway that is completely unaffected by the vagus nerve, and you can get anterograde conduction, so it can go from the atria down, or you can get retrograde, which goes from the ventricles up. So the most common type of AVRT is Wolff, Parkinson, White syndrome. So what happens is, similar to the AV-NRT, where it had a closed loop within the AV node, this is a closed loop out of the AV node. So it usually happens in young patients, and we have broad complex ECGs. And I'll explain that in a moment. And you have a short PR interval because we're not going through the AV node, so there's no delay. And this is just a note that you can't give verapamil or digoxin to AF that's caused by Wolff, Parkinson, White, because it tries to slow down the AV node, and in this situation it's not going to work, and it will just say, well, bugger you, I don't need the AV node, and it'll go do whatever it wants, in simple terms. Essentially, if you dull down your AV node, it'll force the path of least resistance, which is via this aberrant pathway. So, same symptoms, abrupt onset, and it means that you can get other arrhythmias. So the ECG, which I have a picture of next, it'll be fast. Sometimes you can get different P waves, and that's because if a positive P wave is moving this way, when you go backwards and you have retrograde, it's going to be inverted. So that kind of makes sense. And you'll have a short PR interval probably as well. And you can have a narrow QRS or the wide one. And wide is because of our delta wave, which is Wolff, Parkinson, White. And again, the management is the same, so catheter ablation. So here we go. Here's the accessory pathway. So what this delta wave is talking about is it's an early slurring of the QRS complex. And why this happens is because the reason why you will get a nice sharp PR interval that then goes into the Q wave is because during the PR interval, it's the AV node delay. If you no longer have this AV node delay, you'll essentially go from your P wave a little bit of PR interval when you're going from the SA node to your accessory pathway. So it'll be much shorter. And then you will have a wide QRS because your depolarization has started earlier than it normally would on whichever side it happens. I hope that makes sense. But essentially, it's getting through too early instead of having the normal delay, which means that you are depolarizing for longer and therefore it's wider than normal. So as we can see here, it's a little bit tricky. Where's a good one? Here. So you can see that it sort of slopes up. This is the sort of ECG you'd see tattooed on someone's arm when they don't really know what what an ECG looks like. Or here in lead 2, they're quite good. That they're not sharp and they don't have that normal Q wave that goes down. They just sort of slope up. And so that's our delta wave. And this is when you have Wolff-Parkinson-White, but you haven't gone into any of the arrhythmias yet. Because if you look at this, it's sinus, there's a P wave, it's regular, but it just has that strange sloping. And in this ECG, some T wave inversion. And I do not know why that's there. Alas, we don't know what that patient looks like, so we can't make any comment. So, junctional tachycardia is when your AV node sort of overrides the SA node. So it can happen in a variety of causes. Heart attack, which is pretty much the cause for anything in the heart. And essentially what happens is, given it's not happening in the atria anymore, the SA node is not responsible. So your P wave is just not even happening. So it can happen anywhere. And you can also get inversion because it's going the wrong way. Essentially, this is just going to look weird and it's not an important topic to know. Ventricular tachyarrhythmias. So these are the 3 types. So you get ventricular tachycardia, ventricular fibrillation, and ventricular ectopics. So these ones come under ED because they present dramatically and they need dramatic management. So ventricular tachycardia is 3 ventricular ectopic beats with a rate of greater than 140. And if it's sustained, then it's 30 seconds rather than just the 3 beats. So the cause of this can be cardiac scarring. So if you've had any open heart surgery or a heart attack, or if you've had pacing leads taken out, any coronary artery disease or structural heart disease, and the big cause is the long QT syndrome. So the complication of VT is that it can become ventricular fibrillation, which is almost synonymous with death. Just kidding, that was morbid. And in the pathophysiology, so it's a big reentrant circuit and it's around one of the valves, and then it moves into the septum and it just stimulates the ventricles faster than it can sustain, essentially. So if you have these just the 3 beats, you might be asymptomatic or you might have a little bit of a palpitation episode. Otherwise, again, if you've got poor cardiac output, then it can be palpitations or syncope, and in sustained events you can get a preceding chest pain or pressure, and then they might just pass out or pass away. So if we're looking at this, you can pretty much not make heads or tails of it. You can see that it's wide and you can see that it's fast, and it's regular as well. So wide, it's greater than 3. And the good thing about the ventricular ones is that you can pretty quickly just look at it and work out what it is. So this is a monomorphic, and I mean there's a few changes up here, but essentially they're all the same. Otherwise, polymorphic is torsades, which I'll show you later, and there's pretty strong AV dissociation given you cannot see a P wave to save yourself. At least I can't. Maybe you guys can. So the management, if they are unstable, you need to shock them. So strictly speaking, there are 2 different types. So a cardioversion or defibrillation. And that just depends on whether they still have a pulse. And there's also different types of shocks that you can give as to whether you're timing it properly or not. If they're stable, you can give medication, so IV lignocaine or flecainide, and then remove any medications that might cause a long QT syndrome. So if we remember back, that's all of pretty much a lot of our antipsychotic medications, as well as our macrolides, and some other medications. So long term, they're given amiodarone, and they can also have ICDs put in. So it doesn't stop the episodes from happening, but it treats it more effectively when they do happen. Otherwise, they can have the scar tissue ablated. Point fibrillation, but it's sort of pre-fibrillatory. It's the same as VT, but just has a different onset, which is specifically contraction during T wave. But this can also become a fibrillation. So you're looking at this ECG, you can see that they go from a pretty much normal rhythm, maybe not quite normal, and then I think up the top is the best way, but you can just see that it just twists around the baseline. It's not all the same, it's getting smaller and larger. So here, as I say, twisting around the isoelectric line is pretty much pathognomonic for torsades de pointe. So going back to actual ventricular fibrillation, there are various causes. It can be one of the immediate causes of death after a myocardial infarction, and any of the electrophysiological disorders. So the Wolff-Parkinson-White that we were talking about, or long QT becoming torsades de pointe. Poor prognosis, just because you have to be very quick in treating this. But essentially, you get a re-entry pathway, it just turns to chaos, and you just get simultaneous and uncoordinated contraction. So unlike the atria, where most of the ventricular filling is passively from the atria, and there's a final squeeze of blood, in the ventricle they're not so lucky. They have to do a lot of work to maintain us and our cardiac output. So when they're not working properly, it's very quickly apparent. So early they might have some chest pains, palpitations, but very quickly they will lose consciousness. They can be pulseless because there's no big contraction of blood, so that there's nothing to feel, and they will have a low blood pressure because of that. When you're investigating this, work out why it's happened, if they have any heart failure in the background, so the CK and BNP. Are all of their electrolytes okay, like we were talking about with the eating disorder, or homeless people, or people who aren't eating properly. Toxicology, and you can do an ABG, so that's an arterial blood gas, or in many cases just a venous blood gas to see if there's an acid-base cause. Obviously, and I mean, maybe that's not obvious, but hopefully you guys will appreciate that we're probably going to try and fix the VF before we then go to coronary angiography. But these are all the investigations, and I think something important to take away is that sometimes we do investigations in waves. So we'll wait for the FBA to come back, and then we'll do our toxicology if it doesn't show anything, or if that makes sense. We'll do our chest x-ray before we do a coronary angiogram. So in this one you can see a bit of VT, and then it's just really close together, just like fibrillatory waves, shapeless, and it's pretty much like a child drew on it. And this will be very fast. So acutely, we're still doing doctor's ABCD. We never get away from this, ever, ever, ever. If they're unstable, you need to shock them, and if it's stable, you just do the same as ventricular tachycardia. But I think the likelihood that you would have a stable VF is probably low. If you've brought them back from this, you need to send them to ICU. And look, at this point, you're probably not going to be doing these things, but technically, if for the sake of knowing, you're going to give antiarrhythmic drugs and beta blockers. Long term, you'll give them something to not stop the episodes, but to stop them when they happen. You can ablate the pathways, and you can give medications as well. And then ventricular ectopics are just ventricular beats that aren't coming from the SA node. So there are various causes. They can happen in anyone. And sometimes you and I might feel them, but they're just from one location in the ventricles that just starts a depolarization, and you may or may not have an actual pulse. You might have them, you might not. Investigations, ECG, you can do a Holter monitor. You can treat it with beta blockers if it's filling fast. I think the most interesting thing about ventricular ectopics is they can happen in patterns. So sometimes people might just have one, and that's fine, nothing happens. If you have 2 in a row, it's called a couplet. If you have 3 in a row, it's called a triplet. And if you have 1 to 1, so you have a normal beat and an ectopic, it's called bigeminy. And then 2 to 1 is called a trigeminy. And I don't know what happens if it's a 3 to 1. But I mean, I guess it would be called a quadgeminy, maybe? I don't know. Maybe it doesn't happen. So this was an OSCE in 2018, which is a little bit scary, but it happened and we can all learn from it. Essentially, they had a patient who had a sudden loss of consciousness, and you had to approach that situation as per doctor's ABCD and do a demonstration of CPR. So one important thing that you need to do is the patient had a pillow under their head and you need to remove that. They might ask, I think they asked, what are some shockable rhythms? And that is VT and VF. And non-shockable rhythms are asystole and pulseless electrical activity. So if you don't have any activity in your heart, you cannot shock what's not there. Essentially is a good way to think about it. And pulseless electrical activity, which I had never heard of before reading Ben Amberg's notes, is essentially if you put an ECG on this person, they would have a normal looking ECG, but they have no mechanical effort. They have no pulse. And you also can't shock this because as far as the computer's concerned, there's nothing wrong, which is also very interesting. In terms of the causes of cardiac arrest, it goes by the name of, I think it's like 6 H's and 4 T's, but I've got more here. And for the most part, it's low. So low glucose, low fluid, low oxygen, low temperature, low or high potassium, and hydrogen ions, which is like low pH as an acidosis. And then your T's can be tablets and toxins, tamponade or trauma, tension pneumothorax, which probably can go with the trauma, thrombosis, and thromboembolism, which are probably the same as well. Sorry. These are a few extra features, which I went through a little bit. Brugada syndrome I saw written down somewhere, but I've never bothered to learn it. Pericarditis we talked about. Hyperkalemia, so you get low P's, some wide and weird QRS, slurred ST, and tall 10 to T waves. So if you imagine you're pulling your ECG apart and your P waves are getting shorter. I can't explain the T waves, but you'll just have to remember that. Tamponade, you get electrical alterans, where you get a big QRS and then a small QRS because it's fighting against the blood, and it can do one good contraction and then it fails. And then it does one good contraction again and then it does a little one. And that's what that happens there. Hypokalemia being the opposite of hyperkalemia. Hypercalcemia, you get a short Q2E interval, and the opposite happens when you have low calcium. And a pulmonary embolism essentially gives you all of the right-sided things. So you get a right axis deviation, P pulmonale, and right ventricular hypertrophy. Obviously, a right ventricular hypertrophy would be more due to chronic emboli rather than an acute one, because you need that time to have the hypertrophy to happen. And the name of it is S1Q3T3, which is meant to be this classic pattern. I never managed to get this to stick in my head. So a prominent S wave in lead 1, Q wave and T wave inversion in lead 3. If you can remember it, you can remember it, but I don't think clinically it shows up much, and in exams they're moving away from buzzwords. And plus, if you just recognize this, even if you don't know what it is, you know that it's PE. Yeah, I don't know how to help with that one. So a little bit of a pop quiz. We'll work through all of these together. So this one I sort of explained at the end, but if we have a look at it, it's relatively regular, but there are some wide complexes that are happening, but there's also normal complexes in there. And when it is normal, there's a P, the QRS looks narrow, and then there's a T. So looking at this, it looks like they're having ventricular ectopics in a 1-to-1 ratio. So this is a bigeminy. This one here, so this one's subtle, but important to get. And I know I'm skipping a few steps and not doing things in the proper order, but feel free to go back through them if you have time. But this one, if we have a look along, we've got a P wave, Q wave. We can't really see a T, but that's okay. But if you focus a little bit closer, you can see that you've got one big QRS and a little one, and a big one and a little one. And they're quite small in general as well. So I was saying that this could be because of a big person. It could be because of an effusion, or it could be because of a tamponade. I suppose an effusion can cause a tamponade, but classically considered to be blood. But there is some sort of restrictive fluid around the heart. So this is the electrical alterans that I was talking about. This is a cardiac tamponade. This next one. So it looks like there's something funny going on with the QRS, but the P looks normal. The T's a little bit tall. And if we have a look, we've actually got a left axis deviation. So it's pointing upwards with our left hand and downwards with our right hand. And I suppose that's looking at lead 3 rather than lead 2, but lead 2 is a little bit isoelectric. It's sort of the same on both sides. There is a T wave inversion here, so it's probably not a super well patient, or they've got some left-sided heart issues. But if we have a look here, that's a W there. And then in V6, there's a bit of a notching. It's sort of a sideways M, but you can see it's a bit wider. So this would be William, which makes it a left bundle branch block. Looking at this one, so it's quite fast. There's only 2 large squares between the R waves, which makes it 300 divided by 2, which is 150. So this is a tachycardia, but the QRS complexes are quite narrow. You can't really see the P waves. The P and the T are blending into each other, and that's just because it's going quite fast. So I know the answer because I got it off Life in the Fast Lane, but this is a sinus tachycardia. So what can happen sometimes if you have really fast heart rates is that you have to give them adenosine to try and slow them down and take a good look at their ECG while their heart's ramping up again. And in that small window where they're going a bit slower, you can see what's causing it. And so maybe there's another reason under this for why it's going so fast, but it could just be a sinus tachycardia. Another way to work it out other than adenosine is on history, if the patient can still talk. All right, let's have a look at the next one. So there's a bit of a gap here, but we'll go through. So we've got a P wave, narrow QRS T, P QRS T, P QRS T. And as I look at these, this PR interval is just getting a little bit longer, and then it's gone. So there's a P there and a P there. So a PR interval that's lengthening, and then a drop. So they're building, and then they drop the base. So this is second degree Mobitz type 1, which is Wenckebach. We're going to look at the rest of the leads as well, and if we have a look even just at AVL, AVL's got it, lead 1's got it, so do the rest of the lateral leads. And if we have a look at V4 and anterior leads, they've all got this ST elevation as well. Global ST elevation, PR depression, and this sort of saddle appearance, that's pericarditis. Alright, this one, so it looks regular. It's 2, maybe 2.5 in between, so that's 100, or there's 3 here, so 100 beats per minute. We've got a P wave, narrow QRS, and a T. It looks pretty good. There's no notching to the P wave, there's no excessive tenting to the T. We've got a nice R wave progression where it's isoelectric around V3. Negative in AVR, we've got a nice axis. Don't be scared to say this is normal. It's a sinus rhythm. But if we have a look at the baseline, so if we have a look, it's regular, but it's not sinus, that's for sure. And we've got all of these flutterings, and it looks like a sawtooth. So these are all our F waves. So if we try, so I sort of gave it away there, but it's an atrial flutter. If we have a look here and we go 1, 2, 3, 4, 5, 6, it's a 6 to 1. And even if we work out 1, 2, 3, 4, 5, 6, 7, about 8. Gosh, 300 divided by 8. I'm going to get my calculator and do that. 300 it's 30. 300 divided by 8 is 37. So this is quite a slow heart rate, but I suppose that's in quite a large gap versus this gap. There is some T-wave inversion, but it is hard to work out where the T-waves are when there's so many flutter waves in there. Moving on, so if we have a look at this one, it looks almost regular, but there's some bigger gaps, some small gaps. This here is almost 1 square, which would be 300 beats per minute. Some larger gaps. It's sort of hard to work out where the P, QRS, T is. Definitely doesn't look quite right there. We can see clear T waves, that's good. If we look at V1, because V1's closest to the SA node, it's pretty shaky. And comparing to the last one, it's not those nice flutter waves, and it's not regular either. So it's going to be AF until proven otherwise. Back. Which one were we up to? This one. So inferior, which we've all learnt together as a right coronary artery. This one, we can see that it's pretty normal initially, and then it just gets this nasty twisting appearance. And this is going to be torsades to point. So it's quite fast, it's polymorphic, and it's wide. So it's ventricular. Just keep doing that. Might be a W in V1. And otherwise making sure everything else looks normal. But given it's narrow and there's no P waves, it's pretty much just atrial fibrillation. Again. So I want you guys to get really good at picking up atrial fibrillation, please. Here we go. So this one starts to give it away pretty quickly because someone's labeled these V7, V8, V9. So what'll happen is they've taken V4, 5, and 6 off, placed them in different places, and called it a posterior ECG. So now we can see, and I suppose if someone's done that, there's probably a reason for it. So when we're looking at these leads, we can see that there's a significant ST elevation here. So they have a posterior infarction. There's some lateral involvement, but if we look at anterior, so V4, or this top right corner, is no longer part of the anterior because it's now V7, it's posterior. So we can only look at V1 to 3, and they've got significant ST depression, which is a reciprocal change because it's on the opposite side to the elevation. And as we know, if you've got a positive deflection, there's going to be an opposite negative deflection on the other side. All right, so we're almost done. So this is a posterior STEMI, which I know is right coronary artery based. Looking at this one, so this is all lead 2, which is interesting. So when we're looking at it, you can sort of see there's a coupling of what looks like T waves and P waves. And then there's a P wave that looks like it's got the shortest PR segment ever, and then it just is creeping closer and closer, and now it's within it. So I think if you mapped this out and you mapped out your P waves, you'd sort of see that these are regular P waves and quite regular QRS, but a little bit too close for comfort. That here they're disappearing into them. So this is 3rd degree heart block. So this one, we've got a small P wave, a wider looking QRS and a normal T, regular rhythm, still sinus because we've got a P wave. It's got pretty much a normal axis. I mean, I'm a bit sneaky because I know what the answer is, but if we have a look in V1, it's wide and it's got an M shape. Like, look at that. Picture perfect. Frame that. And then I think this would be the W there as well. But I think if it's that wide and it's that convincing in R1, then you just call it a right bundle branch block. Almost done. So we've got a P wave, QRS, an inverted T, PQRS inversion. So we've got inversion all the way along. So lead 2 is part of our lateral lead, inferior lead. So we'll have a look at them. Oh, there's only inversion in there, none in 3, but another one in AVF. And if we just go through all of them, T wave inversion here. A positive T wave in AVR, which is usually negative, so that's technically also a T wave inversion. AVL, so throughout all of the lateral leads, there's T wave inversion, and in the septal and anteroseptal, it's pretty much normal. So what do you guys think this is if we've just got T wave inversion? So you can get T wave inversion as an early sign of ischemia. Something else that's been flagged is that maybe there's ST depression in 2. Okay, no, I think I was crazy. Maybe in V5 and V6 though, given we know it only has to be one small square in the chest leads, which are these guys, and half a small square in the limb leads. So it could be that this is an early non-STEMI, so some ischemia happening. All right, so I don't know if you guys will remember me mentioning this one, but hopefully, if we look through it, it's pretty much regular. Got a P wave, QRS, T. QRS is probably verging on starting to get a little bit wide. Maybe some T wave inversion or like a biphasic T wave, which I couldn't tell you what that means. And the obvious thing that's staring at us is these R waves are just running into each other, and that's our left ventricular hypertrophy. All right, my goodness, I was really testing you, wasn't I? So we've got some written questions now. So a 26-year-old woman presents acutely unwell with shortness of breath. Her ECG shows sinus tachycardia, deep S waves in lead 1, inverted T waves in lead 3, and Q waves in lead 3. So this is one of those buzzword type things where it's saying S1, T3, Q3. She's a young woman. It's acute. She's short of breath, and she also has a tachycardia. So this is based on the history, even before you've gotten to the ECG. You'd be wondering, as one of your red flag do not miss conditions, if she has a PE, which she does. If we look at question 2, a dominant R wave in V1, inverted T waves in V1 to 3, and a deep S wave in V6. So this is sort of the difficult thing about ECGs, is translating it into words. So given it's talking about, and look, to be honest, I actually don't know the answers to these because I haven't written them down. Given it's talking about V1 and V6, I suspect it's talking about one of the bundle branch blocks. And given it says inverted T waves, I'm wondering about ischemia as well. So it could be talking about G with a new left bundle branch block. A deep, wide S wave. So S wave is when the deflection is down. And if it's deep and wide, then you're sort of getting probably a W impression, which would make it a right. I don't know. We'll find out together. I'm sorry. These questions are hard. I should have tried them. C, right. Did I say that? Oh my gosh, maybe I did. 3, so prolonged PR interval, depressed ST segment, flattened T waves, and a prominent U wave. And once we start talking about U waves, we all know that we're talking about potassium. So we'll have a look up the top. There's only one potassium here. Oh no, there's 2, sorry. So flattened T waves is the opposite to the nice little tall tented T waves. And tall tented T waves are when you've got a lot of hyperkalemia, when you have lots of potassium. And if you've got a U wave, it's going to be hypokalemia. So I think this is hypokalemia. Sinus rhythm with a bifid P wave, which is best seen in 2, V3, and V4. To be honest, I don't know about what that localization is meant to indicate, but our bifid P waves, we know, looks like an M. So it's from mitral issues. And there are 2 of them, and I didn't anticipate that. And given, I'll go through this in our murmur lecture as well, but given a bifid P wave comes from a thickened, hardened, a right atrium, I think this is going to be stenosis, because what happens is you need to contract harder because there's more pressure. It's, Poussin's, that sounded inappropriate, but Poussin's law, where if you've got a smaller radius, there's less flow, more pressure. I really hope this is going to be mitral stenosis out of that long explanation. And it is. A 65-year-old man presents with chest pain radiating to the jaw. The ECG shows ST segment elevation in 2, 3, and AVF with T wave inversion in V5 and V6. So F for inferior. This sounds like an inferior myocardial infarction, which is F. So that is everything. If you guys have any questions, I'm so sorry. I think this recording will go for about 2 hours, which is abysmal. But come back to it, and it's sort of helpful for anyone who was at Alfred. I hope it's helpful anyway. We'll see you guys next time.